This is Dr. Stewart from Bunion Foot and Ankle Center, and I'd like to spend a little bit of time talking about osteoarthritis, and more specifically, I'm going to focus on a condition that commonly affects the foot called Hallux Limitus / Hallux Rigidus. Osteoarthritis is the term used to describe degenerative arthritis. Degenerative arthritis is simply what it means, degeneration of our joints. We're machines. We're just like a machine. A car can fail, a vacuum cleaner can fail. So just like the parts in those machines, our parts can have wear and tear. And it's important to understand how a joint functions so we can understand why it may fail and why it may degenerate. And arthritis can happen all throughout the body. And osteoarthritis generally occurs from either trauma or injury, or just the way our anatomy is and using it over and over and over again. The more you use something, the more potential there is for it to fail over time. And our bodies break down just like any sort of machine. And this is a foot model, and we're going to talk really about the big toe joint here. This is the first metatarsal bone. You're looking at a foot model here. You can see the first metatarsal bone, and the toe here is the phalange. And you can see here on the cap of the bone, we have the head of the bone, and in a human being, there's cartilage on this. And just like a chicken bone, you can see the white shiny layer of cartilage. And the best way to think of the way a joint functions is really to picture two hard-boiled eggs. We're going to use an analogy of a hard-boiled egg. And if you have two hard-boiled eggs, one on this side and one on this side, the analogy here is that the shell of the egg, which is lining the egg, is the same as cartilage, and the egg underneath is actually bone. Think of it like that. And what happens is when these structures move against each other, the intact shells, the motion is nice and smooth. It glides. There's no jamming. There's no pain. There's no rubbing of the bones. And patients, humans, function without pain. Our joints move freely. If you have structural changes, meaning that your bones may be aligned in a certain way, which I'll show you later on, or if you've had trauma, like a turf toe injury, or a fracture across a joint, like an ankle fracture, or if you've just used the body part excessively, you've been a marathon runner your whole life, or you played sports your whole life, you can get wear and tear of these joints. So what happens is the shell, in this analogy, starts to crack. It hits itself, and over time that cartilage or that shell starts to break, and instead of having shell on shell, you now have egg on egg, which again, remember, the egg in this analogy is the same as bone. And the bone, when it starts rubbing against bone on each side or even one side, the bone starts to become exposed. That's when the pain sets in, because the nerve endings are in our subchondral bone. Subchondral bone means the bone that's right underneath of our cartilage. And when you start to develop that, you develop limited motion because our body senses pain and we start guarding. So if a normal joint moves like that, when they start to get the pain, the joint may have a little less motion, and then you feel pain, you stop. So anytime something hurts, you guard. Guarding is basically if someone throws a punch in your face, what do? You go like that, you protect yourself. So your body naturally guards itself or protects itself when there's arthritis. And again, it can happen from injuries. A common foot injury that occurs that causes arthritis in the big toe joint is a turf toe injury. And the treatment for arthritis throughout the body is very similar. Particularly for the foot and ankle, you want to focus on lower impact activities. Anything that's causing high impact on the foot is going to cause jamming of the joints and more pain and pressure. So we want to really limit walking and running and focus on exercises such as biking, swimming, seated weight training. You want to make sure you're avoiding barefoot walking. You're wearing nice supportive shoes. You want to wear sandals in the house. I wear these sandals called UFO sandals. They're really nice and comfortable. And I try to avoid barefoot walking just in general. But for anyone with arthritis, barefoot walking can really promote arthritic pain. We will treat the conditions with ice. We'll use medication sparingly as needed. We can use Tylenol. Tylenol works very good on the pain associated with the bone when there's bone-on-bone rubbing. Osteoarthritis, by definition, it's a non-inflammatory condition. It's a mechanically induced condition. You can have inflammation associated with it, but that's why Tylenol is actually the preferred drug as long as you can tolerate it. There's no problems with your liver. or no contraindications. And you want to make sure you take the appropriate dosing, and make sure you consult your physician when taking the medications. Anti-inflammatory medications should really be used sparingly. In general, people tend to take these a lot more than they probably should. They can affect blood pressure, your stomach, they can cause ulcerations, they can have effects on kidney. And you want to make sure that there's really true inflammation when you're taking these medications. So if there's a flare-up, anti-inflammatories could be beneficial, but generally this is a mechanically induced problem, meaning that the structures are rubbing against each other and it's not true inflammation. You want to make sure that you are fitted for orthotics if you are having foot and ankle arthritis, because orthotics can limit the motion. When you're going through certain motions that are promoting the pain, orthotics can be a really good device that we can fabricate and make to put in your shoes that can take pressure off of certain areas, redirect the weight bearing. And we can reduce your foot and ankle pain by using orthotics. And understand that arthritis is a progressive condition. It gets worse over time. It's unfortunately something that once you have it, it's not going to go away, and you're really managing the symptoms. Steroid shots can be used, but they should be used very sparingly. You want to make sure that there are no adverse effects from the steroids, like atrophy of the skin or degeneration of the joint. And I really try to spare using steroids for cases that are really not amenable to other therapies, or someone is just in severe pain. But you don't want to make the habit of repetitively injecting certain spots particularly, and you want to try to focus on using steroids in a very limited fashion. And if the pain gets real bad, arthritis is treated with surgery. And in the foot and ankle, there are different types of surgery depending on the degree of arthritis, frequently surgery is done for osteoarthritis of the foot and ankle that's non-responsive to conservative care. So you always want to focus on conservative care first, and if that fails, then we start talking about surgery. And I'd like to really focus more on Hallux Limitus and Hallux Rigidus. And these are really the same condition that are on a continuum. So Hallux Limitus literally means it's Latin for limited. And again, going back to the foot model, you have your first metatarsal bone and you have your big toe. And this joint, the big toe dorsiflexes, which means goes up. And when it goes up, pulls up, that motion should not be painful. And when we walk, when you pulse off your foot, when you push off your foot, your big toe goes up. It comes up. And when you start to get a jamming of that joint on the top of the joint, you can start getting pain. And that, when you have that jamming and pain, that is a feature of a condition called Hallux Limitus. And Hallux Limitus is where you have pain in the joint, but you generally have spared cartilage damage. So there's no damage of your cartilage itself. And I'm going to bring my camera over here, and we're going to pull up some x-rays. And we're going to look at some x-rays of what a foot looks like with arthritis of the joint that has spared cartilage. So this is a patient who I've been taking care of, who has a little bit of narrowing of this joint space. So if you look at this joint space, there's a little bit of narrowing. You see a little white in there, but overall that bone looks normal. And you can see there's nice black space in here. And when there's a little haziness or whiteness in between the joints, that indicates a little narrowing of the joint. And if you look at the side view of this foot, you can see that the bone, the first metatarsal bone, is actually elevated. It's lifted up. So what happens is you can see that the big toe is actually sitting lower down, and this is common with what we call Hallux Limitus. And this is a structural deformity, meaning the patient was born with this bone sitting up. And because this bone's sitting up, when this toe moves, it jams right here. But you can see there's a nice space in there. And we know that when we move this joint on the physical exam, that this is not causing, there's probably not cartilage damage in there. And the only way to really truly know whether or not there's cartilage damage in there is to open up that joint. But particularly with women, high heels will really exacerbate that, because as that toe tries to come up, It's going to force that bone down more and drive it into the ground. And this is a condition of tolerance. And this is actually, I have a lot of people come in, more women than men experience this, but don't get me wrong, men can experience this as well. But I think we tend to see this a little bit more in women because of the shoes that they wear. And we certainly don't do surgery to try to get people back in certain shoes. But we do see this a lot in younger individuals because of a structural change. And when you tell patients, oh, it's arthritis, they look at you, like in shock because they're young. And I've done surgeries as young as people in their 20s for this condition. And it's really the result of a structural change, not necessarily because they've been running on it forever. So it is a degenerative process, but it can be promoted by structural changes of the foot. And this patient actually went on to need surgery. And there are different types of surgery that we do for this. And there are surgeries where we can spare the joint, or there are surgeries where we have to sacrifice the joint. And in this case, we were actually able to spare the joint because the cartilage was okay. And because the cartilage was okay, you can see what we did here. And I'm going to just show everybody that you can see that what I did on this particular surgery, if you look at the preoperative x-ray, you see the space is narrowed. And here you see that we've widened up this space nicely. We've really gotten this space opened, and the joint is nice and round, and this toe moves smoothly. And we actually put another implant here to get that bone down further, and also to provide a little length to prevent this bone from shortening. We've added a little length back. And if you look at the lateral x-rays on this same patient, again, this is the lateral before. And if you look at the lateral x-rays on this patient afterwards, I actually just flipped this around. This is the same foot. I flipped this x-ray just so everybody could see. This is the bone that's elevated, and you can see here that the bone is now down and aligned because we've cut this bone and plantar flexed it. And we put this implant here to also bring this bone down. So you can see that this bone is now sitting even so that when this big toe moves, it's nice and smooth. And this patient, this was her first foot, and we actually just operated on her other foot with the exact same condition, and she did very well after this. She's doing very well. She's about 3 weeks out from her second surgery, and we were able to spare the joint. Now, there are other forms of arthritis that the joint cannot be spared. When arthritis gets very advanced, you'll have patients that come in that look like this, and they have this big bump on the top of their foot, and this is a bone spur. And what a lot of times patients will comment is that they think that they have a bunion. And Hallux Rigidus is the term that's used to describe more advanced arthritis of the big toe joint. And that's where you really see these bad advanced degenerative changes around the joint. There's extreme limitation of motion. Patients are transferring weight that way to the outside of their foot, and they really have a hard time getting around. And when it comes to this condition, an x-ray for something like this, you will see a lot of bone spurring. When we look at this x-ray, you can see this large bone spur. You can see that the joint is narrowed. These patients have a lot of pain. And when you have patients that come in with this, a lot of times they're really coming in at the point where they're not living with this condition well. You have these spurs here. The joint space is very narrowed. And when it comes to this condition, there's really only a few things that you can do. You can treat them with a very rigid shoe conservatively, go through the conservative mechanisms, but when the arthritis gets so severe that the joint is limited and they're in a lot of pain, it becomes a surgical problem. And in my practice, there are two options that I will give patients, and it really hinges on how much motion you have remaining. And one option, and you can look on our YouTube channel, we have this videotaped, is where we put an allograft over the first metatarsal bone, which basically means we open up the joint and we spare the motion, but the joint surface is destroyed because the joint surface is destroyed even before we open the joint up. and we clean that joint surface off, we round it off, and we put a cadaver graft over the bone, and all that's doing is it's a natural cushion. And I can't really show you an x-ray of that because you're not going to see that on x-ray. But what that does is it allows the bones that have loss of cartilage to now move against each other with a cushion in between. And that procedure can be very good and can have very good long-term effects. And the advantage of that procedure is that it spares the joint motion. You still can preserve joint motion. And we really do that when patients have x-rays like this and they still have reasonable motion. Some patients come in, like this particular patient, that just wasn't even a candidate for that because the motion was so limited. And going back to the graft procedure real quickly, the graft procedure, the advantage is that you can spare motion. However, if that procedure fails, or if the patients fail to do the range of motion exercises like they're supposed to, that joint will stiffen up and can require conversion to a fusion. So, it avoids the need to immediately go to a fusion, and the goal is never to do the surgery and hope to go to a fusion, but the patients need to be very clear that if that surgery fails, the joint will need to be fused. And if the patients fail to do the range of motion, which unfortunately I've had some patients where I've done this, and they've stiffened up, and actually in the times that's happened, it's stiffened up and the bone more or less fused on its own, and they did not need surgery, but they had the equivalent of a fusion. And a fusion is a procedure where we would, and I'm going to show everybody what a fusion looks like, where we basically take a screw and we remove the cartilage surfaces, and you can see the postoperative x-ray on that same patient, and we're taking the cartilage surfaces and we're literally putting a screw across here, and we're fusing these bones, and we're making one long bone, and we're eliminating the little motion that they had. And patients always, when you, not always, but a lot of times when you talk about fusing a joint, their eyes tend to pop out of their head when they hear the word fusion, and they're thinking, oh my God, how am I gonna move my foot? Well, most of the patients who have fusions aren't moving their foot already. They're not having a lot of range of motion to begin with in their foot. So when you fuse their joint, you're eliminating the very small amount of range of motion that they have left by bringing those bones together and eliminating the pain. They do have to continue to wear a stiff shoe. A lot of times we'll make them an orthotic afterwards. But patients who have fusions do well. This was a runner and a biker, and he did very well. He got back to all his activity and went on to be happy. We have people that run, ski. The limitations for fusions really come into play when you are doing a lot of bending or stooping. If you work as like a plumber or an electrician, that can probably be very irritating because that joint is not gonna move, and you can get weight transferring to that part of the foot. So you really have to make sure that when you're doing these surgeries, you address any other deformities. Sometimes we'll have to shorten some of these other bones. But that is how, if an implant is not an option, I don't do implants in the big toe joint anymore. I'm not saying that they are not reasonable to do. I just have not found them to be very successful in my hands. I find that either fusing the joint or putting an allograft when there's more advanced hallux rigidus, or sparing the joint and doing decompression procedures, meaning doing surgical procedures outside of the joint where there's hallux rigidus. And again, surgery is only done when conservative care fails. And a lot of these principles apply to all forms of osteoarthritis in the foot and ankle. So if you'd like to learn more about osteoarthritis of the foot and ankle or Hallux Limitus / Hallux Rigidus, simply request a consultation on this page or give the office a call. Thank you.